Good morning. My name is Sage Davis. I'm a nurse practitioner and director of clinical quality, and this is Dr. Jack Ebright, our
Good morning,
infectious
Sage.
disease
Yeah.
physician. So we're here to answer some questions. So there's just been so much information going around, and sometimes it's hard to sift through.
Yes,
so,
it is.
So the big question on everyone's mind is, okay, what really is this coronavirus 19?
Yes, this is a different and apparently more deadly virus in terms of numbers as compared with earlier coronaviruses. We first became aware of coronavirus, which is an RNA virus, back in 2002 and 2003 when there was the SARS outbreak. And approximately 1,000 people across the world died from that illness. And then fortunately that infection pretty much died out itself, and we haven't seen it back. Subsequent to that, there was another coronavirus called the MERS agent, the Middle Eastern Respiratory Syndrome virus. That's still with us, but mostly in the Middle East and not really tracking through wide areas of the world, as is this third coronavirus called SARS coronavirus 19. So all three of these have been coronavirus, which is an RNA beta coronavirus genus that we have been recognizing even before those outbreaks as usually just a cause of a cold. You know, maybe 30% of upper respiratory tract infections over the last many years have been understood to be due to coronavirus, but nothing particularly serious as we have with these three outbreaks, the current one being with this SARS coronavirus 19. It's called coronavirus because of the appearance of the virus in its envelope in the electron microscopy. So it kind of looks like a crown, apparently. So that's it.
Yeah, so these coronaviruses in the past that cause colds, is that coronavirus 19 or is that, like, who knows what type of
The
coronavirus?
spectrum of clinical illness that coronavirus 19, or SARS coronavirus 19 as it's officially called, is still being worked out. But it appears that it can cause a wide range of clinical illness, including probably just a cold. Indeed, probably a large number of asymptomatic cases. And then patients who might come to us with more than that, a cough, a disturbing cough, a fever, both, or severe respiratory distress. So there's a wide range of spectrum of clinical illness that appears to be possible with this new coronavirus. It's not unlike the other viruses we've encountered recently. We remember West Nile virus that became entrenched in the United States in 1999, and that the great majority of those cases were relatively modest illnesses. Fever, cold symptoms, maybe a rash, but only a small percent, maybe 1 or 2%, had the more deadly CNS disease like meningitis, encephalitis, cranial nerve palsies. That's typically the kind of picture we get with viral illnesses, this wide spectrum of possible presentations.
One question a lot of people have is, how is this similar or different from influenza? We know that a lot of people die in the U.S. from influenza every year. How is this different? Because it does seem like the response is so different.
Yes. Influenza presents almost identically with the symptomatic coronavirus. Fever, cough, sore throat, fatigue. These are, the overlap of symptoms is so great that they're practically indistinguishable to us. So patients who walk in with these symptoms could be either or other respiratory viruses for that matter. So it's difficult to distinguish. The symptoms are very similar. Influenza is notable for causing a mortality rate in the United States of, in any given year, of between 10 and 30,000. So it's a very high mortality, but given the percent, the case fatality rate of influenza is considerably lower than what it appears that the current coronavirus does. So the world case fatality rate for our current coronavirus infection looks like it's around somewhere between 1 and 3%. So the entire world population right now, it's about 3 to 3.5% case fatality rate. But in South Korea, it was actually 0.85. It was less than 1%. So there's a range of case fatality. Even so, the case fatality rate with coronavirus appears to be probably tenfold higher than influenza. So
who would be more at risk for those, for poor outcomes, like
that
hospitalization?
appears to be pretty clear now, especially with the data coming out of China. The people at greatest risk for severe disease or death from coronavirus are the elderly, that I hate to admit begins at about age 60, and especially elderly who have underlying comorbid illness, chronic lung disease, chronic heart disease, diabetes, especially smokers. These are people who have a great risk. When we look at that data from China, the mortality rate for patients over the age of 70 went up to about 6 to 8%, the case fatality rate, as compared to maybe at the highest 3.5% overall throughout the world. So we're especially concerned for patients who have underlying comorbid illness and for those who are in the older age group.
So how is coronavirus spread and how easily? So for these people who might be in that high risk category, how, just some guidance of how it's spread and how easily, how concerned you need to be.
It's primarily spread through droplet dispersal of infectious droplets from a cough or a sneeze. It may also have a minor spread, it appears, through contact on surfaces. The virus can survive on surfaces for maybe up to 3 days, as best we know at this point. But that seems to be a relatively minor means of spread, at least at this point. So the major means of spread seems to be the oral and upper airway droplet dispersal from coughing or sneezing.
So is it just in the air everywhere? People have that question.
We don't know that yet. It doesn't appear to be in the air everywhere as best we know now. It appears that it's most likely to be dispersed within a 6-foot radius from a person who's infected. So that's why we have the social distancing rule, trying to keep people separate from one another out in the community and within the clinic as best as possible within a radius of 6 feet.
So everything is closed, it seems. Not everything, but it feels that way. And that's unprecedented, at least in my lifetime and anyone in my family's lifetime.
I've never encountered anything of this type.
So it creates this feeling of we're all gonna die. And so could you explain, what's the rationale for these closures? Is it because of the fatality rate, or what? What is the rationale for the reason for those closures?
Right. I think Dr. Tony Fauci has explained this extremely well on his daily updates with our Vice President. And as he puts it, I think very effectively, we're trying to reduce the peak rate, or kind of flatten the curve, I think is the term he uses. The reason for the dramatic closure is to reduce contact from person to person as much as possible. And if we can do that, we can reduce the spread. Almost certainly we can do that. That is, almost certainly we can reduce the spread by reducing person-to-person encounters or proximity. Why would we go to that extent? The reason is that we're trying to avoid the very rapid increase of cases to an extremely high peak that will simply overwhelm our resources in the United States and around the world for that matter. So healthcare facilities are already being put under enormous pressure to care for the patients that are coming. You can imagine what would happen if we had no control whatsoever, if there was no social distancing, and this the number of cases increased exponentially to an extremely high peak, all of whom would be flooding into our ERs. There would be no way we could possibly manage them. So the idea is to flatten the curve, to reduce the number of cases at any one time. Now it may be that the total number of cases over a year might remain the same, but if we can diminish the number in a given time, we'll have a better chance of having sufficient hospital and clinic resources to meet their needs. That will also give us more time to develop a vaccine, which might take a year or more to do, possibly find a medication or more than one medication that would actually be effective in treating patients, and also give us more time to develop really excellent point-of-care testing. One of the things we're finding in our clinic right now, and probably in yours as well, is the absence of any point-of-care testing which can be done at the time that you're seeing a patient and have results within 15 to 30 minutes, so we would know where we stood, and the patient would know as well. We don't have that. By giving ourselves more time and flattening the curve, we may develop those tests and to a much greater advantage for us.
So it sounds like it's very much a strategic
yes, it's absolutely necessary.
Okay. And then what can we do to reduce our risk of getting COVID-19, and what can we do to help our immune systems and whatnot from having poor outcomes?
I don't know what we can do to help our immune system per se, but it makes sense that we would try to get plenty of rest. Those people who are smokers, this would be a great time to stop smoking, and I'm talking about cessation of not only a cigarette smoke, but any kind of smoking, whether it's vaping or smoking marijuana, that should all cease. Otherwise, the self-protection, we've heard multiple times that it has to do with frequent hand washing, a 20-second rule, using either soap or water or alcohol-based rubbs, avoiding contacting your face as much as possible with your hands, obviously avoiding contact with other people, handshakes, etc. And staying home and not going to places where larger numbers of people are gathering. So I believe Michigan has already declared that there's going to be no gathering over a number of 10 people at any one time. I think that's true. So those are the things that we need to be implementing individually.
So I'll speak a little bit to...
Let me also add one other thing. I know that the influenza vaccine has been controversial with a lot of our patients, but this is still a very important thing to get. So if you haven't been vaccinated yet for influenza, this would be still time to do that, and that would help to diminish the likelihood of getting a confusing infection, influenza, which could confuse the doctor and the patient for being coronavirus.
Yeah. Wonderful. So I'll speak a little bit to what Covenant Community Care is doing in that regard. So you talked about social distancing to flatten the curve. So one thing that we've done is we're working on telehealth. Telehealth is recently covered by Medicaid. We are working hard, to get that up and going. So, patients, don't be surprised if you're contacted to be asked to do a visit over the phone. We are working towards implementing possibly video. So that's all new stuff, even as of this week. So you'll be hearing more from your provider offices. Another thing as well is that if you think you might be sick, we are asking that you call ahead and talk to the nurse prior to coming to your appointment, so they can help you sort through, are you sick, are you not sick, and if you are sick, what the best next steps are. So that's what we're doing to try to, with that 10 person rule, if we can not have a really busy waiting room and things like that, those are some things we're trying to do. So this leads to the next question is, if somebody has fever, cough, trouble breathing, what's the next step?
I think that's the most vexing question that we have right now. And I've been talking to our own medical director, Dr. Ott, and talking also to the epidemiologists at the White Medical Center and St. John's Hospital, where we send a lot of our patients.
Yeah.
Importantly, everyone now to whom I have discussed this agrees that the requirement for a travel history has now fallen off. Even as recently as a week ago, the definition of a person that was at risk for having coronavirus infection was a couple history of both either fever or cough or lower respiratory distress, plus a travel to China, Hong Kong, South Korea, or other hot bed places in the world. That travel history is no longer pertinent. So now, the history of simply having a new fever or a new cough, and obviously respiratory distress, is sufficient to start entertaining the possibility that that person may have the coronavirus. That ushers in a remarkable practical question and problem for us. What do we do with those patients? We have a lot of patients like that.
Right.
So what we're trying to do then is to limit them from coming into the facility as much as possible. The doctor who is being seen or questioned about this will have to make a judgment as to, do we bring this person back in the clinic, put them in a private room, don all the personal protective wear, or do we try rather to keep them in their car, discuss their case over the phone, which is currently what we're doing here at the Moros Clinic site. And those who meet those criteria, if they're not particularly sick, we're probably just going to advise that they go home and stay home for 14 days. Those who are more ill and we're more concerned about them with respiratory distress, for example, we need to send to our emergency rooms with a call ahead to our ED staff and explain, we have Mr. So-and-so coming, we have concern about the coronavirus for this reason, and we wanted to give you a heads up that they're coming. Here's their name and their birthday, so you can look them up. So that's really what we're trying to do. Part of our practical problem right now, and the challenge we have at the Moros site, is we have still a very limited number of protective garments and protective material for our doctors and nurses to use. And so we really need to see a marked increased supply of our protective gear. And until that, we really need to be very judicious in who we bring into the clinic to be evaluated.
And that shortage is everywhere, with the personal protective equipment. And So we are, working hard on that. We, with the declaration of the national emergency, we might get more. We don't know when that will be, but the main message is we want people to call ahead, and because the process might change as time goes on, with
it almost certainly will change.
Yes, how this outbreak is coming out.
Dr. Ott was showing me a listing of COVID-19 hotlines. So what we can do is those patients who have symptoms that suggest COVID-19 infection to call different places in the area where the coronavirus can be tested. That includes the Beaumont hotline, DMC and Henry Ford, and we're giving out numbers that they can call and arrange to be tested.
Okay, perfect, wonderful. With all of this, going on, we are still really trying to adhere to our mission, which is to show and share the love of God as seen in the good news of Jesus Christ by providing affordable, integrated, and quality health care to those who need it most. And we just really feel like, wow, our patients, they do need us during this time, and asking God for wisdom and praying for our patients and our community. Yesterday was St. Patrick's Day. There wasn't much going on.
No.
On St. Patrick's Day. No.
A few people were wearing green, I noticed. That was about it.
That was about it. So St. Patrick, he was a missionary, and he has a famous breastplate prayer, which is a prayer that he and his congregation would do to put on God's protection for the day. So I'm going to read a portion of that as we close. I arise today through the strength of heaven, the light of the sun, the radiance of the moon, the splendor of fire, the speed of lightning, the swiftness of wind, the depth of the sea, the stability of the earth, the firmness of rock. I arise today through God's strength to pilot me, God's might to uphold me, God's wisdom to guide me, God's eye to look before me, God's ear to hear me, God's word to speak for me, God's hand to guard me, God's shield to protect me, God's host to save me, from snares of devils, from temptation of vices, from everyone who should wish me ill, far and near. Christ to shield me today against poison, against burning, against drowning, against wounding, against coronavirus, so that there may come to me an abundance of reward. Christ with me, Christ before me, Christ behind me, Christ in me, Christ beneath me, Christ above me, Christ to my right, Christ to my left, Christ when I lay down, Christ when I sit down, Christ when I arise, Christ in the heart of every man who thinks of me, Christ in the mouth of everyone who speaks of me, Christ in every eye that sees me, Christ in every ear that hears me. I arise today through a mighty strength, the invocation of the Trinity, through belief in the threeness, through confession of the oneness of the Creator of creation. Amen. Thank you very much for joining us.